Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Welcome back to the Gastro Girl podcast, your trusted resource for all things digestive health. I'm your host, Jacqueline Gollin, and today we have a very important episode brought to you in collaboration with the American College of Gastroenterology's Patient Care Committee. This episode is focused on eosinophilic esophagitis, or EoE, an increasingly recognized condition affecting both children and adults. Now we're diving into the latest ACG Clinical Guideline for the diagnosis and management of EoE, a comprehensive update that reflects the most current understanding of this chronic immune-mediated disease. Now, to help us break it all down in a way that makes sense for patients and caregivers, we're joined by two incredible experts who co-authored these guidelines. Dr. Amanda Muir, a pediatric gastroenterologist at the Children's Hospital of Philadelphia and faculty at the Perelman School of Medicine at the University of Pennsylvania. We're also joined by Dr. Nirmala Gonsalves, a gastroenterologist at Northwestern University, Feinberg School of Medicine, and the Kenneth G. Griffin Esophageal Center. Today, we'll be covering what EoE is, how it's diagnosed, and what's changed in the latest guidelines, which also cover the best treatment options available for both children and adults. So whether you're living with EoE, caring for someone with it, or just want to understand this condition better, this episode is for you. So first of all, thank you both for joining us today. Nice to see you.
Thanks so much for having us.
We're so excited. For those who may be joining us, our listeners who are unfamiliar with eosinophilic esophagitis, I thought we could start with a little definition and overview, and then we can talk about some of the differences between the pediatric and adult, maybe the presentation of symptoms and how it's diagnosed and all that good stuff. So let's just jump into it. So can you tell us, either one, what EoE is and what are some of the signs and symptoms? Dr. Gonsalves, would you like to
Sure.
start?
I'll take this one. So the definition of eosinophilic esophagitis is what we consider a clinical pathologic diagnosis. What does that mean? It means that patients need to have symptoms and they need to have abnormal biopsies. So symptoms we'll get into shortly, but symptoms of esophageal dysfunction and abnormal biopsies showing a certain number of eosinophils, over 15 in a specimen, will make this diagnosis of eosinophilic esophagitis. We think about this as being a chronic immune-mediated condition, a food antigen-driven disease, and not a classic food allergy that you may think about. So it's not like someone who's eating a peanut, they're breaking out into hives and their throat is closing, but it's a chronic exposure to common foods that are creating this inflammation in the esophagus. And that inflammation in the esophagus is ultimately what leads to those symptoms.
So, Dr. Muir, can you explain some of the symptoms? We'll start with children. Like, what are some of the common signs and symptoms that appear in children?
Yeah, so one of the reasons I think this is such a tough disease, especially in the primary care setting, is that the symptomatology is so diverse. And we have patients who are coming in with what sound like very run-of-the-mill pediatric issues, like feeding issues, reflux, abdominal pain. And a lot of the feeding issues and vomiting type of symptoms tend to be in the younger patients. We definitely see them in the older patients as well, but the kids who are losing weight and not refusing to eat and refusing to advance textures tend to be the much smaller children. And then as the children get older, as they're presenting, the symptoms seem to morph into more things like belly pain, reflux, and dysphagia in the older adolescents going into adulthood. So I do think it's one of those diseases where you have to have a really high index of suspicion as a gastroenterologist and as a primary care physician to think, gosh, could this be an early sign of EoE? Do I need to refer this patient? Do I need to do a scope on this patient?
So, Dr. Gonsalves, what about in adults? Like we hear, I've had friends over the years, I've talked about this in numerous other episodes, where they were struggling with, eating like a chicken kebab and they would constantly have it stuck in their throat. And my friend, she had to visit the ER several times. And people may not be aware. We've seen this over and over again in our comments and in our emails from patients. They had no idea what this was. So what are some things that people should be aware of, and they may be experiencing right now, but they have no idea this could possibly be EoE?
Yeah, that's a really important question because, as you point out, many patients don't even recognize that how they're swallowing is abnormal. And so, as Dr. Muir was speaking, the symptoms really do vary, but in adults, they are very predictable, meaning that the majority of patients have what we describe as dysphagia or difficulty swallowing. And that sensation that food is going slower down their esophagus or getting hung up in different parts of their esophagus, and sometimes having food impactions. And what that means is when they're eating that kebab, it's going into their esophagus, not their airway, but in their esophagus and getting lodged there, and they can't bring it up or down. And that's a complete food impaction. So those are the common presenting symptoms of adult patients with EoE, but it's really important for clinicians to also recognize that some of the patients may not elicit these symptoms to you because they have spent a lifetime of accommodating for the abnormalities and the narrowing that they have in their esophagus. And so some of the things that patients may do are they chew their food excessively, they may cut their food up into small pieces, they'll puree their foods. They take a very long time at that dinner table. Many of our patients will say, I was the last one to leave that dinner table or the, table at the cafeteria in college. And they'll lubricate their foods. They'll turn away pills and tablets. And a lot of times they avoid the food entirely that causes these symptoms. So some people may never eat steak or may never eat that chicken kebab because it's getting lodged. And so for clinicians, it's important not to just ask patients, are you having difficulty swallowing? Because I'm always surprised at how many patients will say no because they're doing all of these mechanisms. So it's very important to ask about these particular questions and how they're eating, what they're eating, and what they're actually avoiding, and if they're avoiding pills. That's a clue for this diagnosis.
Now, Dr. Muir, you've seen some of the same things with kids taking a longer time to eat, maybe drinking lots of water, being afraid to eat, or pretending they don't like it. And when actuality, there could be something else going on, correct?
Correct. And I think the other thing is that the behavioral patterns around feeding in little kids, things like, oh, my child gets up and runs around the kitchen
Oh,
instead of sitting down to eat. And eating can, if it's really tough for someone to eat, they may really try to avoid it. And those may come out as behaviors. And so it can be really hard in kids sometimes when they can't say this hurts or this doesn't feel good, or they don't even realize that it hurts or it doesn't feel good.
that's such a great point. Now, going into before we dive into the really meaty stuff of the guidelines, how is EoE diagnosed? And I don't know if is there a difference between how it's diagnosed in kids and adults? Dr. Gonsalves, would you like to start?
Sure. So it's important to know that the condition is not just diagnosed based on these symptoms. Patients really do need to have an endoscopy. It's diagnosed by endoscopy and getting tissue. That's really the important piece of this because, like we talked about, it's a clinical pathologic diagnosis. So these characteristic symptoms should lead us to think about referring to a gastroenterologist, getting that endoscopy. And the endoscopy is just a tool, a device, a procedure where a fiber optic camera about as skinny as my pinky goes into the mouth, down into the esophagus and the stomach and the small intestine. And we take samples of those areas in order to get that biopsy to the pathologist. And then the pathologist looks at the piece of tissue under the microscope and counts those eosinophils, and that's ultimately how we diagnose it. An important part to recognize is that the disease is very patchy. So some patients may have had endoscopies and they've never been diagnosed with this. One, maybe they didn't get biopsies, or two, maybe we didn't get enough biopsies. There's a really critical number of biopsies that need to be taken in the esophagus, at least 6 in multiple areas of the esophagus and targeting areas of abnormality.
So at the same time, so when you go in and do the endoscopy, you want to do it in 6 different areas, correct?
So when we go into the esophagus, yes, absolutely. It's important not to just look and visualize that esophagus, but also take those samples, and taking at least 6 different samples along multiple areas of that esophagus. And when we see these characteristic changes, which we'll talk about in a bit, we want to target those changes.
Dr. Muir, how do you handle this in children, especially really young children?
No, it's very hard sometimes to convince pediatricians, especially when the esophagus is much shorter and there may not be as much landscape to biopsy, or if it looks inflamed or the biopsies may look like they're bleeding a little bit more than usual. It can be hard to convince pediatric gastroenterologists to take 6 biopsies, but I still maintain that we should still take the same number of biopsies, even though the esophagus is smaller. I think sometimes the pediatric esophagus fools us because it's more likely to look normal earlier on in the disease course. And so people tend to be like, oh, it'll be okay. We'll just get 3 or 4. But really, we need to make sure we're hitting our 6, even if the esophagus looks normal. If EoE is on our differential diagnosis, we have to make sure we take 6 biopsies or else we could miss it. And then we won't be treating the patient adequately.
And you do these in young children, the endoscopies.
Yes, we can do them, down to a 0-day-old if we need to.
Oh, wow. Well, I mean, that's good.
Hopefully not.
No, hopefully not. But to go back, why the pediatric esophagus may look better because it's a progressive disease, right? So someone who's 30, 40, even 50 years old getting diagnosed. I think I had a 70-year-old man tell me on one of the episodes in the comments that he was diagnosed in his 70s, and he's been struggling with eating and swallowing his whole entire life.
Yeah, I think the new guidelines really tease out one of the things the old guidelines back in 2013, I think.
Yes.
We're still up in the air about. So the old guidelines and the way we used to diagnose EoE before is that every single person before they got a diagnosis of EoE had to have at least 8 weeks of a high dose proton pump inhibitor. And so all the patients who we were scoping would have this 8-week lapse where we would then see, and then if they didn't respond to that and they still had these eosinophils and these findings in their esophagus, even after 8 weeks of therapy, we would say, okay, now this is eosinophilic esophagitis. However, I will say with time, we've realized new things, and we realized that proton pump inhibitors in and of themselves are a therapy for eosinophilic esophagitis. And so these medications can actually help treat the disease in about 40% of people very successfully. And so now we realize rather than using this as part of the diagnostic algorithm, it's part of the treatment algorithm. And we can scope patients without any medications. And that's probably better because we can get a clean diagnosis. And then we can start therapy after with proton pump inhibitor therapy if we want to.
Interesting. Dr. Gonsalves, do the guidelines also refer to the clinical symptoms as part of the diagnosis too? Did that change any?
Yeah, no, thankfully that didn't change. And as Dr. Muir was pointing out, I mean, the old guidelines were from back in 2013, so over a decade old. And in that time frame, I mean, so much has happened with this disease and the evolution and the research, the proton pump inhibitor moving towards treatment being one of them, but also additional therapies that needed to be considered. And symptomatology has remained relatively the same, but it really shed light on the differences in symptoms between the children and the adults, really focusing more on some of these adaptive behaviors that we didn't know as much about previously, and making sure that we're not just asking the simple question of swallowing abnormalities, but focusing on those adaptive behaviors, both in children and adults.
No, that's really important. And can you stress here, I think this is an important place to do this, why it's so important to get diagnosed early?
Yeah, with eosinophilic esophagitis, there is a significant delay in diagnosis, and pediatrics and in adults, and it could be anywhere from 8 to 10 years in terms of a delay of diagnosis for many reasons. Not getting referred to a gastroenterologist, not getting that endoscopy, not getting enough biopsies, not getting the right diagnosis when you do get the biopsies, many different things. And a lot of times it's those adaptive behaviors. People just learn to live with this because they say, okay, that's just how I swallow, and they don't recognize that that's abnormal. It's imperative, and part of the focus of the guidelines was to help explain, get earlier diagnosis, earlier treatment, because when we think about what happens in EoE over time, patients start off with an inflamed esophagus. As time goes on even further, there's a lot of scar tissue that forms and what we call fibrosis and stiffening of that esophagus. And as time goes on even further, there's more and more scar tissue. And that is why we think about this happening over time. This may be why we explain the differences between children and adults. So if we can intervene earlier in that process, we can prevent those strictures and ultimately the complications that we're trying to avoid, like the food impactions.
One of the most exciting things about the guidelines for me is like you said, the evolution of all the science and research and advances, especially in the treatment. I mean, that's huge. I'm really excited to get into the treatment approaches. And again, we've done numerous episodes that dive deep into, these alternatives, these options. So from a guideline perspective, it's exciting to actually hear this actually in a guideline. And guidelines are important because that's what clinicians use as the gold standard of, guidance when they're working with patients, correct? If a patient's listening, like, what is a guideline? So I think this is exciting. So one of the things that the new guidelines recommend is the multidisciplinary approach to treating EoE.
Sure. I think when we think about EoE, we have many different types of providers that provide care. So, and I think it varies kind of depending where you are in our country, how we treat it. So in different regions, I think it's handled a little differently. There are, as a gastroenterologist, we're the ones that end up diagnosing this disease. So I do think we have a large part of the ownership because we're the ones performing the endoscopy, we're the ones reporting biopsy results. But in this population of patients who have eosinophilic esophagitis, there's such a high level of comorbid atopic diseases. So many of these patients have, up to 70% have asthma, bad atopic dermatitis, IgE-mediated food allergies, all of which can get kind of all jumbled together with the eosinophilic esophagitis. We definitely have patients where their dysphagia is actually made worse because they also have really bad oral allergy syndrome. And being able to talk to your physician and have an allergist who can talk to you about your oral allergy syndrome separate from your eosinophilic esophagitis can be an important way to come together on this disease. And so while I think we as gastroenterologists do a lot of the day-to-day medication prescribing and scoping and reporting of results, we do work very closely with dietitians, especially in patients who are doing dietary therapy. And we work very closely with allergists, especially as we start to reintroduce foods in very atopic people or handling comorbidities when we have a lot of topical steroid formulations.
Oh, thank you. Now, Dr. Gonsalves, in terms of treatments, the medications that are now available have changed as well since 2013. Could you explain some of those and what patients need to know?
Sure. So I think whenever we think about treatment, we think about medical therapy, we think about dietary therapy, and now we have some newer agents in terms of biologic therapies, which fall under medications. The big branches of medications include those proton pump inhibitors, as Dr. Muir mentioned. And a big highlight of what the guidelines shared is that, the dosing of proton pump inhibitors need to be what we consider high dose proton pump inhibitors. That's the equivalent of something of omeprazole 40 milligrams once a day or 20 milligrams twice daily. And those doses may vary a little bit in children, but that's what we consider the treatment for EoE with PPIs, proton pump inhibitors. And the other important part that the guidelines stress is we need to really counsel patients on why they're being given these medications. Any of the medications or any treatment modality, because some patients may say, why are you giving me this medication? It's for acid reflux. I don't have acid reflux. I don't have heartburn. But there are lots of different mechanisms that those proton pump inhibitors work in. One is reducing acid. Another is helping to repair barrier function. A third is an anti-inflammatory property on that esophagus itself. So the key part of the guidelines and the recommendations are to explain that. So proton pump inhibitors being one, swallowed topical corticosteroids being another modality, and then, of course, biologic therapy. And I'll let Dr. Muir talk about the swallowed topical corticosteroids.
Sure. So I even swallow topical corticosteroids, which have been around for a long time, are starting to evolve as well. So I think, we have our methods where we, retool the asthma inhaler, and it has to be an HFA inhaler. And we have patients kind of place it in their mouth with their mouth kind of firmly around the inhaler. And this can be hard in pediatric patients because as pediatricians, we walk around telling everyone they have to use their mask and spacer. They have to use their mask and spacer. And then now in EoE, we're telling them to take away the mask and spacer and use a different inhaler for their EoE, that they use them separate from the asthma. And we have them spray the inhaler in the back of their throat and swallow. And then I think of this as kind of lotion for your esophagus, these topical steroids. So if you swallow the steroid and then wait nothing to eat or drink for 30 minutes. And that's probably the most important part. The other ways is we have these budesonide oral suspensions, where you can either retool a ampule of budesonide that's usually used in a nebulizer and thicken it with Splenda or honey and swallow it. And again, nothing to eat or drink for 30 minutes. And now we have a new medicine that's actually FDA approved as a budesonide oral suspension that comes in what looks like a Crystal Light packet. And you shake it up and you can actually swallow it. And it's already the right viscosity. And then you don't have to worry about carrying around your honey or your applesauce with you. You can just have that packet with you and take it. So it does add for convenience. And I think it standardizes the approach. You don't have to worry about the mist coming out your nose. You don't have to worry about mixing your applesauce right. Like, this provides a nice standardized approach for patients, and it eases the burden a little bit.
Now, is this for pediatric patients as well?
So we do use the budesonide in much smaller doses than the FDA approved in smaller kids. And that's why we use the ampules, because the budesonide oral suspension is only FDA approved for 11 and up. And in smaller kids, we want to use much smaller doses. So we use.
And is the duration shorter too? Like, you don't do it forever, right?
Yes,
or how does that work?
Unfortunately, since this is a chronic disease, patients end up on medications forever. I will say we do try to get you on the lowest effective dose. And that's different for everybody. You know, we may start at a higher dose and wean over time, just doing a scope to make sure you're still in remission on a lower dose. But and while patients may not be on this therapy forever, they will be on something forever.
And that was what I was going to ask you. There may be times when the doctor recommends that you switch for whatever reason. And that we talked about, there's a new one that came. The biologics have really emerged since 2013. Dr. Gonsalves, would you like to speak about the biologic options for patients that they should know about?
Sure. There's been a lot of clinical studies that have looked at targeting different allergic hormones or cytokines and blocking them to prevent eosinophils from going to the esophagus. Dupilumab is one that's been FDA approved in May of 2022 for adolescent and adult patients, and just last year for pediatric patients as young as 1 year old and over 15 kilos. And what that medication does is it targets two allergic hormones, IL-4 and IL-13, kind of blocks those signals and prevents eosinophils from going to the esophagus. It is a biologic therapy. It's a weekly injection medication, and it has been shown in clinical studies to reduce both the eosinophils in the esophagus as well as symptoms. But as Dr. Muir was saying, it is a medication, just like anything, any type of medication that would need to be continued. We talk to patients about their EoE being similar to asthma, just like someone who has asthma might need to take an inhaler every day to keep their lungs open. Someone with EoE may need to take a medication every day to keep their esophagus open, or take foods out of their diet to keep their esophagus open. So we really do counsel them on the need to continue a therapy. And we may switch therapies if something's not working, or something's not working at the time, or there's a better thing that is fitting for their lifestyle at the time. But continuing therapy is crucial.
Oh, no, thank you both for that insight. Now, I wanted to ask, dietary therapy is also really an important factor. How does dietary therapy fit into the overall management of EoE for both the pediatrics and for adult patients? Dr. Muir, would you like to give us some insight on for the pediatric side?
So I always think these are all choices. And so there's the medicine bucket of therapy and the diet bucket of therapy, and which is right for you at what time in your life is different for everybody. And so just because, diet therapy sounds like there are no side effects, I often tell my patients, there are social side effects. Birthday parties are a really big social part of being a kid, and not being able to eat what your friends are eating in a birthday party is very hard on some kids and fine for other kids. And it just kind of depends. And so thinking about the social side effects as well is important. And so the way we kind of approach dietary therapy in general is maybe a little different in kids and adults, but I think there's two ways to do it. So you either kind of do a step-up therapy where you add foods to try to find which ones are lead to remission, or you start with a whole bunch of foods and then systematically add them back in. In kids, we tend to do the former, where we just eliminate milk and we say, okay, all the milk in your diet, even baked in a muffin or baked in a cake, we're going to try to take all that out of your diet. We'll scope you in 8 to 12 weeks. We'll see where we are. And if that works, then that's great. And if it doesn't work, then we also will eliminate wheat. And we kind of do base it on which foods are the more likely to be causing problems. And that can be a little different in kids because in depending on the kid, some kids don't have any soy in their diet anyway. So you're not going to eliminate soy from someone who doesn't have any soy in their diet. So you just want to kind of think about their diet history and what foods they're actually eating and what could be the culprits.
And how about with adults, Dr. Gonsalves, do you find the same? It's just what a personal preference, or sometimes it's complementary to a medication therapy as well?
Yeah, I would say it's definitely shared decision making and personal preference. So when we talk to our adult patients, we will go through the various options, various medications from the PPIs, topical corticosteroids, biologics, and then dietary therapy too. And we talk about pros and cons of each of the options, the different effectiveness of each of the options. And then I really kind of talk to the patient about what their goals of care are, what they're trying to accomplish, like what is important to them. And for some patients, it shocked me actually when we started doing the studies in adults because we did not think it was a food trigger in adults like it was in kiddos. I was proven wrong by myself. But no, I mean, I did not think anyone would want to do a diet as an adult. And I'm shocked really at how many people are interested in trying to figure that piece out. And just as Dr. Muir was saying, there's no right way to do dietary therapy. We talk about those different options from taking all the common foods out. And in adults, the top two drivers really are milk and wheat, and then followed by soy and egg, and next nuts, and seafood tends not to be a driver at all in adults. And we talk about taking those all out and then adding them back versus starting simple, taking one or two things out and then, moving up as they do in children. We haven't seen the same type of effectiveness as just taking out milk in adults as they do in children. But we have a conversation with the patient, and whatever direction they would like to go, we support them in that. We also, just like Dr. Muir was saying, we do try to keep in consideration their lifestyle. So I will have a long conversation. And if they're traveling a lot for work in the next, like however many months, I say this is not the right time to do diet. If they have a ton of vacations stacked up, we say it's not the right time. If it's a college kid about ready to go to school, we try to wait until they come home from college. So we really try to set them up for success, meaning most patients, if they're interested in diet, they just want to do it one time. They don't want to do it multiple times. So you just have to get them successful right off the bat.
Now, typically, do you recommend that your patients, whether they're adult or pediatric, work with a dietitian to start off with or engage with? Like, what do you usually recommend to your patients?
So I'll start with the adult approach, and I think there are very unique pediatric considerations that Dr. Muir will hit on. But yes, I mean, I think when we're counseling patients on diet therapy, I think it is critical to have them connected with a dietitian or a nutritionist, or if you don't have access to that, getting important resources that are available to provide that to the patient. Because many times patients will come to our clinic and they will have started a diet and people have not provided them with a good framework. So they don't know that maybe whey protein was actually milk and they've been taking this in all along, or that there were lots of contaminations or things that have hidden contaminants in it. So you really want to just support them, give them resources so that they know if you are avoiding milk, what are the things that you can take? If you're avoiding all the 6 things, what are the foods that you can still take in that give you that full nutritional profile? So absolutely, I think working with a dietitian is critical from an education standpoint, making sure that they're nutritionally sound and complete. And also checking in, doing check-ins with patients. I think it's a partnership, when we treat EoE patients, no matter what we choose, but particularly with diet, because we talk to them throughout this whole process and do check-ins and say, okay, how's it going? Have you had any contamination issues? Have you had any adherence issues? Because we will push their endoscopy back if that happens. And I know there's really important considerations with feeding on children, so I'd love to hear from Dr. Muir.
So one of the things to think about in kids that's a little different with diet therapy is if you have someone, since a large portion of our patients come in and they're already have weight problems and they're already having feeding problems and they're already extremely the pickiest eater in their family or the pickiest eater in their classroom, to remove one of the 5 foods and those are the only 5 foods that they're eating may be impossible. And so we tend to stress to the kids who really have severe feeding issues and who have severe nutritional limitations, that diet therapy may be impossible, or they have a list, of 7 IgE mediated food allergies, and there's just not really room to substitute in proteins. And what I usually say is, I realize you are very invested and you want to do diet therapy, and that's an important thing. This may not be the right time. When you have a toddler, the most important thing is gaining those feeding skills, like learning how to eat, learning how to chew and lateralize food and swallow it is a really important skill for young toddlers to develop. And so while you may want to do diet therapy down the road, and I will totally support you, we might need to use medications right now, teach the child how to eat, grow, thrive, get them to a good place. And then at that point, when they have 20 foods, eliminating 2 will be no big deal. And so I kind of work backwards that way. And, while you're picking this therapy now based on where you are, this doesn't have to be your forever therapy, and there's probably room to change.
That's a really important point. And I wanted to ask about elemental diets. Is that it? What do the guidelines say about those? And can you explain what they are?
Sure. So I will say I don't really have any patients on an elemental diet anymore. We have some that still use elemental formula as an adjunct to their therapy, or to make sure that they're gaining weight. And if they're very limited as far as drinking milk and soy and pea products, there's definitely a group of patients who use elemental formula, but the strict amino acid diets are tough because they're not nearly as palatable as the other formulas that we use to help children gain weight. And they can be very costly and hard to get covered by insurance.
That's good to know. And then the final thing that's mentioned is esophageal dilation, which sounds very painful. Is it?
So yes, it is. Esophageal dilation is really important part of therapy. It's a really important part of adjunctive therapy, meaning just dilating that esophagus is not treatment enough. We want to make sure that patients are on medical or dietary therapy in addition to fixing those strictures, because what happens with all this time, inflammation is going to lead to scar tissue and narrowing of the esophagus. And I describe it to patients as being a speed bump. There's a speed bump there that food is just getting hung up on. So we can only open that speed bump a certain amount, usually with medical or dietary therapy. And sometimes it's not open wide enough, and we actually have to stretch it. And there are different devices that we would open up that esophagus. And the goal of doing that is to prevent those food impactions from occurring in that esophagus. The side effects in terms of complications with dilation is really, really low. And this is pooled studies across the board. So if you do it properly, and the guidance from the guidelines is to start low, go slow, and there's whole guidance on how to do that, but really being very cautious with dilation and stopping when you see that disruption really decreases any of those risks of perforation. However, chest pain or pain with swallowing can happen in about 74% of patients. So when I talk to my patients in the clinic, before we even get to the endoscopy suite, I always talk to them about the risks of endoscopy, but particularly the risks of dilation, the fact that there may be some chest discomfort afterwards. And usually we have patients who have had dilations on a liquid diet the day that they go home, and then they advance their diet as they can tolerate, but just to prevent and minimize the discomfort. But really explaining that up front is very, very helpful for them to understand that there may be some discomfort after a procedure.
And just for Dr. Muir, do you do these procedures in children as well?
Yes.
Oh, wow.
So we do have some children, and sometimes it's rather young children who can develop these strictures early on in life, and they do feel so much better once you can get them to a critical diameter. So
that's great. Now, before we get into how to talk to our doctors about our EoE, maybe we're wondering if we have symptoms, or maybe we have been diagnosed and we stopped our treatment because we thought we felt better, but we really aren't better. I want to ask you, did we miss anything in terms of the guidelines that we should highlight for patients?
I would say the only thing that we touched upon, but the only kind of take home point too in the guidelines was about the maintenance piece. And that maintenance therapy is really critical. We talked about it, but just to highlight that again, it's in the guidelines that once you've been on a therapy, whatever therapy that is, we should continue that to prevent those complications.
Yeah, and I think that's an important point, not only maintenance, but also follow-up and surveillance, right? Because it's progressive. And we get this all the time. I'm sure you hear, oh, but doc, I feel better, but yeah, but we should really check to see what your eosinophils are looking like and your esophagus looks like. Can you talk about that? Because I think that is very important.
Yes, I mean, there is a huge symptom histology disconnect. So, how patients are feeling may not reflect what's going on in their esophagus. So, yes, as part of the guidelines, there is definitely a recommendation that with each intervention and change, you should have that follow up visualization and endoscopy of that esophagus to document and show that you're achieving what we need to see is that improvement in the inflammation, the visualization of the esophagus, and their symptoms.
No, thank you. Dr. Muir, do you have anything to add to that from your perspective as a pediatric GI doctor?
Sure. One of the things we also had in the guidelines talked a little bit about when to initiate feeding therapy in kids. And I think it can be hard because some kids never have developed those skills and are having trouble progressing. And I think what we know is that feeding therapy is something that's based on positive reinforcement. And so, in order to make progress, you have to have a good feeling when you eat. And so, kids who are struggling in feeding therapy, who have EoE, you may need to take a pause and say, okay, let's get our EoE into remission, and then we can think about how we can then teach you how to feed, because it can just be a system where they're in these intensive programs and they're really struggling, and we might just have to pause, get them in remission, and then move forward.
So I want to give two scenarios as we close, and I want to ask your suggestions to patients on how to approach this with their doctor, or maybe they have to call a new doctor. The first one is how to start the conversation, whether you're a parent with a child who's you're kind of wondering if they may have this, or an adult who recognizes that they do some of the adaptive behaviors and they've been doing these adaptive behaviors for a long time. Maybe they've had a trip or two to the ER. What is your suggestion, how they could start this conversation with their provider?
Yeah, sure. I mean, I think the big highlight is to first recognize that these symptoms are abnormal. And I think that's a big thing from a patient awareness and education feat that we have, is to share this with patients. The sensation that things are going slower down your esophagus or getting stuck, or you need to drink water to push something down, or you're avoiding textured foods, that's abnormal. That's something that you should speak up about. And that's not always asked about in some, clinical scenarios. So that's a really good thing for you to share with your physician and say, hey, by the way, when I'm eating, I'm experiencing this. I'm having food getting caught. I have to go retch it out in the bathroom, or I have to drink a lot of water, or sometimes I have to stand up and walk around and let it pass. What do you think about that? I think that symptom, as soon as a clinician will hear that, they know that there's something that is going on in that esophagus that warrants that referral. So really starting that conversation is very important. And especially like you bringing up the history of having to go to the emergency room, or maybe having these episodes that resolve at home. Those are all things to bring up. And then the other thing is pills. Some people don't even tell us that they can't swallow pills. And so there could be lots of different nuances behind swallowing pills, but that's another thing. If there's a reason why you've been doing chewable vitamins and not regular vitamins, or crushing things, share that with your physician, because that will clue them into asking, well, why are you doing that? Where do you feel it's getting caught? Is it something with an oral texture, as Dr. Muir deals with children? But those are conversations that are really important.
And Dr. Muir, I wanted to ask you how, most of the parents are probably dealing with their pediatricians. How well recognized are the clinical signs and symptoms recognized in primary care pediatrician offices? And how could you help? What could a parent who's trying to advocate for their child, how do you help them navigate to get that referral to a GI doctor?
Yes, I think the allergists also send us tons of patients. And so allergists tend to find patients who, they just happen to say, how are things going? And, the parent, in an already atopic patient, if your child is then vomiting on top of it, they've been vomiting a lot lately. And then it kind of comes to, so I will say we do get a lot of referrals from the allergist. But I think it can be really hard as a pediatrician, because something like 10% of kids have feeding difficulties. So that's a huge number of the population. And so trying to tease out. So I always think A to B is like the number one like risk factor, especially in kids. If you have someone who's having trouble feeding and they're atopic, if you have someone who's vomiting and they're atopic, like that person, it might be an easier referral. The other ones may unfortunately be tough. But I would say people who don't respond to a trial of antacids, that's another good place. And then anyone who's losing weight.
And for a parent to, to push. No, I think, like, what do you suggest for a parent to kind of, as a parent, you may know gutly, like, this isn't right. There's something wrong.
And it's kind of exactly what Nimi said, to recognize there's a problem. And it can be really hard if you already have a kid who has tons of energy and loves to get up and run around, to realize that might not be normal. So like sometimes it's like recognizing that there is a problem is the hardest part, because, slow swallows might just seem normal to you. And your kid running around during dinner could be also very normal. So it can be really hard to tease these out.
Great. And our final question in closing, because I think this is another important point. I mean, it's all important points, but this one, are those patients who maybe were diagnosed a long time ago, thought they were fine, maybe they lost their insurance, stopped going to the doctor, and they're listening to this, or someone shared this with them, and they're still, getting stuff stuck, things aren't right. How do you help them reach out and get care again? Like, what are your main points and tips for these people?
Just come back. We don't care how long it's been.
Yes.
Well, why should they too? Why should they? Why is it important?
So I will say, from the adult standpoint, the real reason why it's so important is we know that if we don't treat this, that esophagus is going to continue to get narrow, and you're going to have more and more scar tissue. And it's a different trajectory for different patients in terms of how long that may take. But ultimately, the concern is that you're going to get a food impaction, and that food impaction is a medical emergency. You cannot get that food up or down. You have to come into the emergency room and then have an emergency procedure. And with that emergency procedure, there can be lots of or higher risk of complications, let's just say, as opposed to a very elective endoscopy where we can biopsy in a more controlled setting and stretch. And that was one other thing I wanted to bring up with our last piece of the conversation when you asked about what patients can say. We've done a lot in terms of awareness in clinicians and gastroenterologists of when patients come in with food impactions in the emergency room to take biopsies at the time of that endoscopy. Same with a patient. I mean, well, it's going to be hard with a food impaction and trying to give a good history. They still can talk and they give us a good history, but that's something that they can advocate for too. If they've never had a diagnosis of EoE, learning about this diagnosis, that this food impaction could be that, and asking that biopsies be taken is another piece that they can chime in on as well.
You guys are amazing. I'm so glad that we had this conversation. I hope this helps our listeners and even primary care physicians find value in these conversations, and they share with their patients as well as GI physicians. So thank you both very much. And if you or a loved one have symptoms of EoE, please schedule an appointment with your healthcare provider. And for more resources, you can visit gastrogirl.com. We have amazing podcast episodes on this very topic, and Dr. Muir has been on a few of them. Also, AppFed is a great organization. They have a great community of support resources for parents as well as adult patients. I really encourage you to check that out. It's appfed.org. And don't forget to like, subscribe, and share the podcast. And if you have further questions and you want some guidance, we don't diagnose, treat, or give medical advice, but it's great for information, is our new Ask Gastro Girl app that has great resources and can kind of steer you in the right direction with all the noise out there on social media. So thank you very much, and we look forward to next time.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.